Thank you for joining us this evening. We are excited here today to be talking about monkeypox. As you can see, this is not COVID conversations today, but rather monkeypox conversations. And so we'll be hearing from Dr. Matt Zahn that my co-moderator will introduce in just a little bit. A couple of housekeeping items. All lines are muted during the program. There's a question and answer box at the bottom of your screen that can be used to communicate with the moderators. Please feel free to post your questions there. The webinar will be recorded and posted to the California Immunization Coalition website afterwards. So you will be able to view the conversation there afterwards. Tonight's conversation is brought to you by the California Immunization Coalition, as well as the American Academy of Pediatrics, California, the California Department of Public Health, and the California Academy of Family Physicians. So we're thankful for the support from all of these organizations. I am Pia Panaraj. I am a PEDS ID specialist at Children's Hospital Los Angeles, and my co-moderator is Dr. Eric Ball, who is a primary care pediatrician within the CHOC Primary Care Network. And I will throw it to him to introduce Dr. Matt Zahn.
I have the honor today of introducing Dr. Matthew Zahn, who works down here in Orange County with us. He's a pediatric infectious disease physician by training, who received his doctorate in medicine from the St. Louis University School of Medicine and has been living in Orange County, California since then. From 2004 to 2011, he was the medical director for the Louisville Metro Department of Public Health and Wellness, and he now serves as the deputy head officer and medical director of the Division of Epidemiology and Assessment for the Orange County Healthcare Agency. He also sits on the ACIP, and today he is going to talk to us about monkeypox. Thanks so much for joining us, Dr. Zahn.
Thanks so much, Eric. Can you all hear me okay?
You're great.
Okay, and I'm attempting to share my screen. Am I having success?
We can see you. You're in.
How's that?
Perfect.
Very good.
Perfect.
Okay. All right. So thanks so much for the introduction, Eric. So Truth in Advertising here. So I am the National Association of County and City Health Officials liaison to the ACIP. So there are liaisons and that there are voting members, and I'm not a voting member. I'm a liaison from NACHO. I do appreciate the chance to talk to you all. I have been strongly instructed that Dr. Ball likes to have the conversation later on in the program, and so I'm going to try very hard not to step on that and get through my slides really quickly. So if it sounds like I'm going fast, I'm trying to get through so we can have the conversation, but appreciate the chance to talk to you all here. So starting out with monkeypox, just the virus itself. So the virus is a double-stranded DNA virus. It is a human orthopox virus, and it is one of several human orthopox viruses, variola, smallpox most famously, but cowpox and vaccinia viruses are orthopoxes as well. Historically, this virus has been around for a while. It was first identified in 1958 in monkeys in a monkey research colony in Denmark, in Copenhagen, hence the term monkeypox. There's a lot of conversation about this as a misnomer, and that monkeypox just as a word may be somewhat pejorative in general. And both the WHO and other entities are thinking about renaming the California Department of Public Health, I believe announced last week or the week previously, they're moving to the term Mpox. So I think an awful lot of the verbiage is still monkeypox, but just be aware that there's a potential change for a lot of reasons. The reservoir of diseases in monkeys, as far as we can tell, it is rodents, particularly African rodents. The first human disease was in a child who was diagnosed with infection in August of 1970. The virus has really caused disease and disease burden in Central and West African countries. That's been true for decades. The number of cases have generally been going up in those communities, in those countries, particularly in the DRC, Democratic Republic of Congo. over time, interestingly, up until this year, they'd seen a bit of a change in that initially it really seemed like most of the disease was animal to human, and then in more recent decades, it was more human to human transmission. But really before 2022, all the disease was on that continent, unless there was a direct importation of animals or some other reason to other places. This is the WHO's current map of disease around the world right now, depicting this year's outbreak of monkeypox. Two notes here. One is simply that the United States is a dark color because we have more cases than any other country in the world. On the other hand, you can see that an awful lot of regions in the world have been affected by disease. These are numbers from California. On the left is a simple number of statewide cases updated today, so 3,369. Oh, I apologize. I have that somehow is not the updated number. That's from the 26th. But a couple things. One is over 3,000. We believe we're over 3,400 cases now. And if you look on the right, the epi curve seems to at least have flattened off and maybe is decreasing in number of cases. The majority of cases in California have occurred in Los Angeles and San Francisco counties. And so when we say decreasing, I think you'd note that some of the places that got hit earliest and hardest are maybe seeing more of a pronounced decrease than communities that have been affected more recently. In terms of race and ethnicity in both and age range, a few things here. One is that looking at the age range, 25 to 44 years of age is our most significant burden of disease. That's really about 2/3 of cases. In the pediatric population under 18 years of age, it's actually at 7 cases today, but under 18 years of age in California, as other parts of the country and the world, have seen very few cases. I would note for Hispanic or Latino, race and ethnicity have really been overrepresented throughout the state. In terms of gender identity and sexual orientation, 97% of cases have been in males, and for those who have been interviewed and expressed an identity, gay or same gender loving or bisexual, has been identified in approximately 95% of males who've been interviewed. In terms of symptoms, so systemic symptoms for monkeypox definitely happen. They've been less prominent during this outbreak than in others described in decades past. Lymphadenopathy is the most prominent symptom. Around half of cases report lymphadenopathy in a lot of case series, so that's pretty common. And the other symptoms, fever, malaise, are sort of non-specific, and a lot of times patients really haven't had these. They really just have rash. More severe cases that have been seen around the country and around the world, proctitis and colitis, and severe symptoms related to this illness. Proctitis can certainly cause discomfort and cause pain. And I think there's been a lot of conversation appropriately about equity and respect for people who may be infected. One of the biggest things for providers to understand is these symptoms can be severe, and being aggressive in terms of pain management. And I think anybody who's been caring for these patients have realized it's been really important to be aggressive about pain management. Other manifestations can occur, including ocular lesions, bronchopneumonia, encephalitis, septicemia, but really proctitis and colitis have really been a big part of the reason that people have more significant illness and potentially need to be hospitalized. Hospitalization reasons: poor PO intake, dehydration, either from general illness or oral lesions, which can lead to poor PO intake, and pain management can be needed. Hospitalization can be needed for pain management. Cellulitis caused by bacterial superinfection can also occur and necessitate hospitalization as well. As of today in California, about 110 cases, I believe, have been hospitalized. There have been no deaths reported in the United States. There have been 12 deaths of over 40,000 cases reported worldwide. The rash is I think it has been, kind of fairly famous, but I think it's worth talking through. And it certainly is a distinct type of rash that goes through stages. The lesions can be well circumscribed and they can umbilicate over time and become confluent. But over time, generally, it can be macular, then a papular, then a vesicular lesion that scabs over. The lesions are not infrequently painful, particularly initially, and they can certainly be itchy. During this outbreak in 2022, perianal and genital disease has certainly been seen. I think that, but it's also worth noting, as the second bullet there, frequently there have been under 10 lesions. So people have very often not had, dozens and dozens of lesions. There have been patients who've been diagnosed who have less than 5 or 1 or 2 lesions. So for people, particularly in known risk groups who have a vesicular appearing lesion, even if it's benign looking, it's worth testing. In terms of testing recommendations, particularly testing, obviously, those with rash or known epidemiologic risk factors, those who have had close or intimate in-person contact with persons in the social network that is experiencing monkeypox infection. And such a social network includes men who have sex with men who meet partners through online websites, through a digital application, or social events. Or obviously anyone who's reporting contact with a person or persons with a similar appearing rash, or a person who's received a diagnosis of monkeypox. But more than that, we in public health, certainly the vast majority of diseases have been seen in groups that are high risk. But the way we gather data, obviously, is smart providers who think about the appropriate diseases. So if a person presents with a classic rash, even if they don't have the classic risk factors, really testing should be considered. PCR testing is the classic, the standard test to do. It's a very sensitive and specific test. The big thing I note is that the sensitivity of the test, as always, is related to the type of specimen collected. A lesion that is vesicular and that has opened up, has been unroofed and then swabbed. Swabbing of that base of that vesicular lesion is really where the money is and leads to most sensitive testing. It's a bit like HSV or VZV PCR testing in that fashion. So swabbing, unroofing and swabbing lesions is really where the money's at. Testing is really broadly available. A few things. Because testing is broadly available, certainly if there's a concern, go ahead and test. The results do come back in 2 to 4 days. The downside is anybody who's tested should be recommended to isolate pending results. But that's if it's out there, we want to test for it. We want to identify it. Certainly the specific populations with risk factors are at high risk, and so providers should consider particularly testing in those populations. I'd also just note, talk to your commercial lab you work with. Different commercial labs have different recommendations in terms of number of swabs that need to be collected, and whether it's a dry swab or viral media should be used for the swab. So make sure that you're submitting the right swab in the right media, and report any confirmed cases immediately, public health. In terms of treatment, Tecovirimat is the antiviral treatment of choice for monkeypox. It acts by preventing formation of extracellular virus, by preventing the formation of the viral complex. In terms of background, to know, there's a human clinical trial has been performed to indicate the safety and the tolerability of the drug. And I would say that use around the country during this outbreak has really confirmed the safety and the tolerability of the drug. The antiviral has been shown, Tecovirimat has been shown to be effective in treating monkeypox in animal trials, but there aren't human trials. There aren't enough data out there to demonstrate the effectiveness of human cases. And so it is available through use of the Strategic National Stockpile and available through the CDC. And I think I have a link for where you can get it. I would also note for those who, for providers who are potentially ordering Tecovirimat. You can order it through the CDC, through the CDC webpage, and I'll have a link to that later. You can order it directly to your provider. It is the paperwork necessary to use the medication has been drastically reduced, and so it's become much simpler. On the other hand, you can also consider reaching out to your local health department. Very often, local health departments have a Tecovirimat pre-placed there. It just makes it easier to acquire the medication depending where you are. This is a slide, and I realized I think I'm somehow working with a slightly older slide deck. Things I note here for Tecovirimat. One is it can be given oral IV. Overwhelmingly, it's used orally. It's a 14-day regimen, and actually this has 40 to 120 kilos. But it is actually, there is now currently guidance all the way down to infants. So there is, even for pediatric age groups, Tecovirimat can definitely be utilized. Considerations for use. So it should be considered broadly for using for patients who have monkeypox. For a classic scenario, a person who has a classic symptoms and potentially underlying risk factors, including known exposure, empiric treatment can be done. You don't have to have confirmed infection to use Tecovirimat. This is a list from the CDC of a prioritized group who particularly should be used. So persons who have significant underlying disease, who are hospitalized, who have high-risk conditions, including those listed, in particular should be used. I would say I was talking to my colleague, Chris Reed, who's a physician working on our clinic here at Orange County, and our STD clinic, who's cared for several patients. And Chris was saying the medication is extremely well tolerated, and the issue he's run into a couple of times is people initially come in with mild symptoms, then they get more severe later on, and has begun it. And so, I think the general sense I've had is that his sense is that maybe being broadly more comfortable using it rather than waiting until someone develops more severe symptoms. And so I think over time, I think people are becoming more and more comfortable. Medication is safe and worth trying to use to protect disease. In terms of close contact, so this is just guidance that as we think through people who have been in contact with persons who have infection. So preventive measures, so always talking to your sexual partner about any recent illness, being aware, and practicing good hygiene. You can see that, the list of human-to-human transmission reasons. So, and more the CDC is emphasizing real contact with skin lesions with either mucous membranes or broken skin from the person who's having contact. So it's not merely my skin touched that person's skin. My broken skin or my mucous membranes had contact with skin lesions really is where the risk is. Respiratory secretions can be a source as well, and fomites can be a source. In addition, again, significant interaction, sexual contact or household contact is where overwhelmingly the cases are being identified in California and around the country. Airborne transmission, it's hard to prove a negative. So we have minimal evidence that airborne transmission is a significant player here, but it's thought at this point that it is still a potential source. Duration of infectiousness. So the infectious period starts from the onset of illness, and it lasts until the lesions have crusted over and the crusts have separated and there's a fresh layer of skin. And I guess I'll add in for us, for Orange County Healthcare Agency, my agency, and I think this is true for many public health departments, we're just seeing too many cases for us to be the arbiter of when isolation ends. We ask for providers to do that. The standard recommendation is CDC and OCHCA recommend that cases isolate at home until the end of their period of infectiousness. I would note that period is long for the time for the crusting to occur and the new skin to develop. That can be weeks. And so actually the State Health Department of California and the CDC have given guidance for if you have to leave, certainly if you have to go to healthcare settings or to have a healthcare appointment or some urgent work situation that's low risk. If you can keep the lesions covered and your respiratory and fever symptoms are gone, you can consider leaving the home. So, this remains the standard guidance, but health departments have started to say, yeah, we recognize it's a long period of time. And I believe I have CDPH guidance, a link for CDPH guidance at the end to talking about this issues for dealing with the prolonged isolation period. Additional CDC comments. Again, this is what I was referring to. Ideally, those with monkeypox remain in isolation for the duration of illness, but that can be 2 to 4 weeks. And so the CDC does give guidance of symptomatic with fever or respiratory symptoms, including sore throat. And so, when you have those fever and respiratory symptoms, you are most infectious. So you're really supposed to try and stay isolated unless you have an emergency or need to see a healthcare provider. Then if those symptoms are resolved for 48 hours, then while the rash persists, you can consider leaving if you can cover all parts of that rash prior to going out. Wearing a well-fitted mask is the age of COVID, so it's always important, but particularly so if you've had symptoms. Just a couple of notes on guidance for assessing those who are known close contacts. And this is a picture directly from the CDC and from the CDC webpage. And so they have higher, intermediate, and lower. Higher is a very relative term here. I think it's important to recognize. And but the guidance now has gotten to a note in that first bullet under exposure characteristics from the CDC: contact with an exposed individual's broken skin or mucous membrane. So if your broken skin or your mucous membranes are exposed, with skin lesions or bodily fluids of a person with monkeypox, that's the sort of close contact that we're talking about. So again, I shook hands with someone with monkeypox, no lesions on their hands. That's not a significant risk factor. And then, of course, any sexual or intimate contact involving mucous membranes, that's overwhelmingly seems to be the source of transmission during this outbreak. And then contact with an exposed person's broken skin or mucous membranes and materials, linens, clothing, etc., that could have had contact with skin lesions or body fluids. So fomites can be a source, but it's again to the exposed person's broken skin or the mucous membranes. For us healthcare providers, gown, gloves, eye protection, and then N95 or equivalent is PPE is appropriate. This is all appropriate. CDC, CDPH, I recommend all appropriate PPE. I do think it's worth noting here that during the current outbreak, we have not seen healthcare related transmission. Doesn't mean you don't do all of the above, absolutely do. But I think it's worth noting casual exposures, even healthcare related exposures, isn't where the money is. It's close contact, household or sexual contact where transmission's happening. For our emphases, and every local health department is dealing with a different burden of disease and different resources, so all to being slightly different. But I think what OCHCA, my Orange County Healthcare Agency, my agency is doing is similar to what's being done around the state. Our primary emphasis, sexual partners and household contacts. Those are the groups that are high risk. Healthcare workers are at relatively higher degree of exposure. I would note we're not recommending follow-up of other patients with no significant exposure, meaning if your patient is in the waiting room, we don't recommend pursuing, waiting room exposures. It's not that sort of contact. Then, occasionally I rode in a car for 7 hours with someone who was diagnosed with infection. That's the sort of thing that yes, does merit further follow-up potentially. We're not following up. I guess I note and for casual contacts, casual social exposures, workplace exposures, waiting rooms. CDC really doesn't provide guidance for those, and the reason is that there's just seems to be basically essentially no risk in those scenarios. The CDC does have guidance for schools, early care and education programs, and sites that serve children and adolescents. There's a web page on the CDC that talks about it, but I think multiple times the guidance indicates that the risk in the pediatric population is low. And, one of their primary messages is settings should continue to follow their everyday operational guidance. So this is not at this point indication that you should be changing your fundamental habits, particularly in school or other settings. Anybody can acquire monkeypox. We've seen it in all age groups at this point, certainly. But we have to recognize here, I think, again, in terms of equity and fairness to persons who may be exposed or may have it infection, I think it is worth noting that there are some situations where there's risk, but there's an awful lot of casual social community situation where the risk is clearly minimal. Vaccination options. So Jynneos vaccine is the vaccine that is currently used and recommended. I think many people are aware that recently the CDC, the FDA, and then as recommended by the CDC, changed their recommendations for use of vaccination. It was previously a subcutaneous specific recommendation. At this point, it is recommended to be given intradermally to persons 18 years of age and older in 2 doses separated by 28 days. For persons under 18 years of age or persons who develop keloid scars, subcutaneous dosing remains. For the pediatric age group, there is no lower age limit for giving the vaccine. The only comment the CDC does have is when you reach under 6 months of age, the certainty of a good immune response to the vaccine becomes somewhat more uncertain. And so you may consider other measures, including a potential antiviral therapy for if you have pediatric patients who are very close contacts and merit post-exposure prophylaxis. So how well does smallpox vaccination, which is really the initial Jynneos licensure, how well does smallpox vaccination work? And the reason I say smallpox is really the study that I think people refer to most was back from in the early 80s in Zaire. 209 cases, a review of 209 cases found 27 episodes of evidence of human-human transmission that led to 47 secondary cases. So in this case review, 70% of close contacts had a history of smallpox vaccination. Back then it was standardly recommended. One of the questions I think that frequently comes up is, well, okay, if I got smallpox vaccination, some time ago, is there protection? The best guess is yes, you probably do have protection even if you've been vaccinated years ago, but the CDC does recommend an update if it's been more than 2 years. But based on this study, they found that for close contacts who had or had not been vaccinated, they found 85% effectiveness against infection for household contacts against monkeypox. Okay, so this is a trial of monkeypox, but looking back to see, okay, if you had smallpox vaccination, what protection offered, and it seems like the vaccination protection is substantial. For post-exposure prophylaxis, so for recommendation during the current outbreak, persons can be vaccinated following exposure to monkeypox. Both Jynneos and ACAM 2000 are both post-exposure prophylaxis options. Jynneos really, as a vaccine, has a more benign safety profile, and so really nationwide, Jynneos is really the only vaccine that's been used. For post-exposure prophylaxis to monkeypox, the recommendation is if you received within 4 days of your date of exposure, it's thought to prevent onset of disease. From 4 to 14 days after your onset of your exposure, it still may prevent severity, so ameliorate symptoms, though maybe not prevent disease. This data is really based on non-human primate animal trials. So there is indication based on those animal trials that in fact post-exposure prophylaxis works. Clearly there's more information to be gathered, but we are certainly recommending this as post-exposure prophylaxis on a routine basis for people who've had close contacts to monkeypox, that is household members and sexual contacts. So now that we're recommending subcutaneous, now we're recommending intradermal routes of administration as opposed to subcutaneous. What is the evidence for equivalence, at least? So modified vaccinia Ankara vaccine, so that the Jynneos vaccine was trialed, or the equivalent of the Jynneos vaccine was trialed back in 2015. 149 participants received subcutaneous vaccination, and 149 received subcutaneous, 146 received intradermal vaccination. And you can see they looked at mean peak geometric mean titers in both groups, and essentially the immunologic response was fairly equivalent. In fact, the intradermal GMT titers were somewhat higher. And so based on this data, it really seems like an intradermal vaccination provides an equivalent take, an equivalent immunization. And certainly the fact that giving the intradermal dose is 1/5 the dose, that allows us to give 5 times as many doses. I think we all know that there's a limitation in the number of Jynneos doses available out there. So the combination of apparent equal effectiveness and increase in number of potential doses has led to the change in recommendations for persons over 18 years of age. In terms of side effects, I think it's worth noting for side effects, a couple of things, I guess. One is that this is from the FDA literature on the trial of this vaccine, subcutaneous versus intradermal. And so the second column is subcutaneous and the third column is intradermal. And this is a list of reactions, of types of reactions following vaccination. And the yellow box indicates that while for subcutaneous vaccination, erythema and induration and itchiness is common, erythema and induration is virtually always seen. So if you get an intradermal dose and is given correctly, then virtually all the time you'll have swelling and redness around that site, and itchiness is extremely common. I would note that if you look above the painted injection site, intradermal doses actually are somewhat less, 91% reported pain following subcutaneous, and the intradermal dosage only resulted in 65% reporting pain. Itchiness is more common following this event, but certainly we're all going to watch this closely over time to see what sort of side effects are being seen or being reported. This is vaccination strategies that are being used in the United States. This is CDC guidance. So who gets post-exposure prophylaxis with Jynneos vaccine? For the top row is people who are known contacts to someone with monkeypox who are identified. And public health is really reaching out to and very often assuring directly that those people are contacted and they receive post-exposure vaccination. So known exposure to monkeypox is without a doubt. That includes sexual contact and persons who are household contacts, or the two main groups that are fitting into that. Now, the second group that the CDC identified is so-called PEP++, and that's expanded post-exposure prophylaxis. And so that's vaccination after known or presumed exposure to monkeypox. And so those are persons who may not have a known exposure to a case, but who are report a recent sex partner who was at some point diagnosed with monkeypox within the last 14 days, or a certain gay, bisexual, or other men who have sex with men, or transgender or gender diverse people who have sex with men who have had any of the following the last 14 days: sex with multiple partners, group sex, sex at a commercial venue, sex in association with event or venue or geographic area where transmission is occurring. So that's the CDC guidance. I would strongly recommend for local providers, if you have groups that you or you have patients or clients who may be at high risk, talk with your local health departments, because different health departments have different epidemiology, different geographic areas, as the CDC says, and different local health departments have a different amount of vaccine available. And certainly the intradermal availability has really changed our potential. So these are the general CDC guidance, but particularly for that second PEP++, talk to your local health department if you're a provider to figure out exactly which risk groups they are recommending vaccine be available to. Finally, persons in occupational risk groups certainly should be considered for vaccination. For us in particular, it has been medical providers who provide care, for example, direct hands-on patient care to patients in STD clinics who are routinely seeing patients with monkeypox, or laboratory workers who are routinely conducting monkeypox testing. So that it really isn't broadly any healthcare worker in an STD clinic or in a direct patient care site. It's really those at the highest risk setting, and similar with laboratories, those who are at particular highest risk because they're doing specifically monkeypox testing. I think this is my last slide, but I always like to really emphasize this. So, certainly we're going to continue to get high-risk population vaccinated. We're still not sure what degree the spread will occur to other community groups. And so when we're saying we know which populations are at high risk, we know right now, but it's really important to make sure that we know over time that we're not missing the boat in terms of potentially other populations being affected. We need to continue our work to make sure that Tecovirimat gets out to providers. We've had success locally, but I think around the state, we're like the rest of the state. We need to keep working on this. Finally, I just note we are now dealing with this, and we've declared a public health emergency in California and in the country. And, this is a virus and a disease that has been present in Africa for decades. And so when we're talking about this, it's really important for us now and certainly in the future to realize there's an ongoing risk in many countries on that continent. And we have a responsibility, in my mind, to assist them as we go forward. So I think this is close to my last slide. Oh, I didn't have a couple links. Maybe I think I somehow got up this is my slides from like 10 minutes ago before I put on my links. So I'll stop there. Happy to take talk with you, Eric and Pia, and appreciate everybody's time.
Thank you very much for that wonderful talk. So we had several questions that came to us at the time of that the audience registered, and there were significant concerns both from our registrants and from the public about the possibility of monkeypox transmission in a public setting. So how likely is monkeypox to be transmissible at a gym or at a party? You mentioned fomites, and what precautions, if any, should be taken?
Yeah, no, it's a good question, Pia. I'll tell you, here's the battle we are dealing with here. Right now in Orange County, we have over 150 cases, far fewer than other communities, but we have no evidence of transmission in casual settings, like I was in the same gym with someone who had monkeypox, or I was at the same workplace where had monkeypox. And I'm not privy to all of the data around the country, but it really seems like if these events happen, they are extraordinarily rare. It's hard to say zero, but the risk is just approximately zero. So unless you have had contact, again, your mucous membrane or your broken skin with a skin lesion, your risk just isn't there. And I was in the same room for a period of time with someone. It just seems like that risk is vanishingly low. So,
Matt, do we know why this hasn't been an issue here in the past? If this has been a virus that's been known for over 50 years, and all of a sudden we have a big outbreak worldwide, why didn't this happen before? And do we think this is going to continue, or this will burn out and we won't see it again?
Yeah. If I knew the answers to the last question, Eric, I'd get, I'd have, get paid a lot more than I do right now, right? I think that certainly sexual transmission among men who have mixed sex with men is a significant potential spread. I mean, there's no doubt that isn't a potential source of spread. why? I mean, that is certainly one of the drivers here at this point. Beyond that, there's been some speculation as to whether it's a viral strain is different, but I think that really hasn't been, certainly confirmed to any degree. It seems like it's the same virus that's been around for decades. I think one thing that has been interesting for genomic sequencing that's been done around the country here, when they looked at initial cases, what they found interestingly was that most of them all were exactly the same genome, meaning they all had been introduced this time, but a handful of cases were actually genomically distinct, meaning that these were apparently some introductions from months or years past. And so I'm not, trying to say there's been a lot of monkeypox around for a long period of time, clearly far more than we have, this outbreak's very different than what we've ever had before. But I think that at least part of it certainly is potentially undercounting. And certainly in Africa, where the virus is more endemic, there's certainly undercounting happen. We know that. So it's probably a combination of a lot of things, Eric.
Do you anticipate that the vaccination strategy would expand to more of the public if we were to have more vaccine available?
Yeah, it's a good question, Pia. I think that we will cross that bridge when we get to it. We have, right now the biggest thing we're doing is following the epidemiology in an environment where we just don't have enough vaccine. So certainly we are recommending those highest risk populations. I think over time lots of counties are slightly broadening that post-exposure prophylaxis. The CDC's guidance is if you've had risk exposure within 2 weeks. Well, sometimes other counties have said, well, maybe up to 3 months, maybe up to a year. Maybe you have general high risk behaviors, so you're not being quite so, proscriptive. So I think there will be some language broadening that's happening and locally, and it'll happen on a statewide level. I do think that, you have to be a little careful about, even within the MSM population, there's a large swath of the MSM population who's really at no appreciable risk, and so, when you think about broadening the recommendations, I'm very hesitant about that, because that will also imply a risk, either concern or stigma that really isn't necessary. So I think there's a balance there.
So a question in the Q&A was, I guess someone died of this in Texas today or yesterday, was hot off the presses in the news.
It's the nightmare, right? I'm getting ready for this talk and I'm looking for it, right? Yeah.
Well, so that leads to a bigger question is how do people die from this? So in Africa, for example, like lots of people die from this. We're not seeing that here. What's the typical way they die from this?
Yeah, so it's, I'd say a couple of comments, Eric. One is that if you suspect there may be undercounting and there be far more cases, that are mild, in Africa, if you look at case series, for example, most of the case series that I can see represent, they describe 50, 100, 150 lesions. Well, what's being described here is 7, 5, one lesion very frequently. So I think what was in Africa, what's been described is a mortality rate of approximately 5 to 10%. There's two clades. There's clade 1 and there's clade 2. 2B is what's here. 2B is the West African clade. Generally, a lower mortality rate has been seen with that clade, but it's still around 3.5% from what we've seen in Africa. So why is it that we have, this handful of deaths for many, many thousand cases here? I think that if you look at case series in Africa, there was one, I believe, from Nigeria in the last 10 years. And these are approximate numbers, but about 110 cases were identified and they had about 7 deaths. They did have 7 deaths. For those 7 deaths, 4 of them were in persons who were known to have HIV and had not received any antiretroviral therapy for at least 3 months. So one is profoundly immune compromised. Two of the deaths of those 7 in that case series were for persons who developed were described to have bacterial cellulitis, so bacterial superinfection of skin lesions leading to sepsis and death. And then the last case was a 1-month-old, and the series didn't provide, the study didn't provide more information. But what I would take from that is, I think it is possible that in a relatively resource poor community, it may be that only serious disease is coming to medical attention and being diagnosed, and maybe the underlying risk factors or the sequelae like bacterial cellulitis may pose a different risk, if the available medical resources are not the same. So I think that's at least part of what's going on here. But I haven't seen, that's Matt Zahn looking through the literature. I've yet to see, WHO or the CDC or someone say exactly why the morbidity and mortality is really been so different than what's been seen in the literature. But I think I would say it definitely seems to be a lot lower than what's been, described previously. And I think it's worth thinking through when we're assessing our risk and figuring out, if you're potentially exposed in a community setting, well, the morbidity and mortality of this virus, really, this is, there's been an awful lot of cases and not a tremendous amount of severe disease.
Great, that's reassuring. We have many pediatric providers on the call, or family practice physicians who are taking care of pediatric patients. What can you tell us about monkeypox in children? What's known here has only been a couple of cases, handful, but perhaps what's known from Africa.
Well, I'm not privy to all 7 cases have been reported in the pediatric cases in California, but in general terms, it is either the potential is to have close household contacts, particularly for younger kids, and for older teenagers, the potential is to have sexual contact in the same way. And so I think that it is one thing that is worth noting that for providers who care for teenagers, many of the same risk factors may be present. And so let's not, again, think about this as just an adult disease. In terms of pediatric illness, it's not surprising we're seeing cases in Africa. Most cases initially for decades were in the pediatric population. Probably that's because the pediatric population in Africa was the first age group that hadn't received smallpox vaccination, which we think protects you. So it had really been weighted toward a pediatric population. The morbidity and mortality was generally seen to be higher there. But again, it's been higher in all age groups there than it has been in the United States. To the degree that we have seen cases, they have looked similar to what's been described in the literature. In general, severe disease has not been seen in the pediatric population here in the United States, but we have seen far fewer pediatric cases. I would just give you the general comment, other than this is my anecdotal comments, and I'm sure most providers are dealing with this. We are also have been, in summertime, and hand, foot, and mouth disease has been upon us for weeks and for months. And again, I certainly, testing is out there and it is available, but we've certainly seen, hand, foot, and mouth disease cases tested, and they're uniformly coming up negative. I think that the other thing that really raises people's concern, obviously, is we have a group of kids, like in a daycare setting, who all have who all have vesicular lesions. It certainly makes you worry more because more cases. But overwhelmingly, they're turning out to be hand, foot, and mouth. So if you're a medical provider and you say this looks and smells like hand, foot, and mouth disease, I deputize you now. You are now allowed to think, yeah, that's probably hand, foot, and mouth disease. You are not obligated to pursue every vesicular lesion and test them all for monkeypox. Looks like hand, foot, and mouth disease in a pediatric population without any risk factors. That's probably what it is.
That was my question. All the patients I'm seeing have hand, foot, and mouth, and then the other half have molluscum, which also seems to look a lot like this. So a lot of
There's
worried
overlap
parents
there.
out there.
Yeah.
So the kids who have received, again, another pediatric question, the children who have contracted monkeypox, has this largely been through household contact?
Yeah. Again, Eric, this is an evolving story, as we say in public health. And I scratched hard from the state and from the CDC. Can I get numbers? I don't have specific numbers, but overwhelmingly what seems to be is household contacts. The one thing I would say, we have no daycare transmission. We're not seeing school transmission. We're not seeing, that casual sort of contact. No, of course, it's all the caveat of very few pediatric cases and school's not been in session to a great degree. But, to the degree you're seeing transmission, pediatric seems the same as adult, which is household contact. And obviously if there's sexual transmission exposure, that's potentially, but household contact, close contact like that. They're starting to vacuum my office. So if you hear a loud hum behind me, I apologize. That's what that is. I'm going to let them do their work, and I apologize if you hear that noise. That's all it is.
You mentioned schools. Now that kids are going back to school, and there's fear amongst both from the parents' standpoint about their kids getting smallpox from a teacher, and then the teachers are fearful that
monkeypox, right? Yeah, I know. I struggled. I'm sure I did it wrong in my presentation too, but yes, no, absolutely.
Right. So both fear from the teacher side and from the child side. And you mentioned that, the schools should just go about their normal infection control strategies. What can you say to reassure both the parents and the teachers?
Yeah, I mean, I think, the data is what's profoundly reassuring, to me. Again, it is close contacts that has led to transmission. Casual contacts in a large number of settings, right? We know we have workers who, are persons who are at workplaces, or who have social engagements, or go to restaurants, or go to dinners. That's not exactly the same as a school setting, but there's an awful lot of overlap there, and there really isn't evidence of transmission. So, and even in Africa, I would note that while more pediatric cases were seen, even in case series from decades past, it is overwhelmingly close contact that is really leading to infection in the pediatric population. That's one thing that we really share with the African experience, is close contact is how transmission happens. If you look in the literature, I can find no description anywhere of a school outbreak ever occurring during the monkeypox anywhere. That doesn't mean that transmission can never happen, but I think it's an indication of the the minimal burden of transmission that happens. I think that it's a struggle for all of us, because certainly in public health, we're always worried about schools, and we're getting, obviously questions like everybody is. A couple of general comments that I'd have. One is that the number of pediatric cases are very small. If we have a pediatric case, your local health department is going to be very interested in that, and is going to work very closely with you at the school to assess the situation and identify risk. So this is not like COVID, where we have so many cases where every school kind of has to do an awful lot of their own work. The number of cases are small enough that if we have any case in that in a child who was in school when they develop infection, we will obviously work very closely with them. I think that the data tells us that those risk situations are going to be very low risk. I will tell you the biggest thing that we worry about, that I think about, is the rumor mill is strong, always strong. And if you have a pediatric case in a school setting, I feel like we're probably going to see a situation where the risk is incredibly low, and then we're just working with a school to figure out how do we get ahead of the rumor mill, because everybody hears about it and the school doesn't say anything. I think messaging in these incredibly low risk situations from a public health side, that's going to be low risk situations, I think, but I think the messaging is going to be tricky, and public health is going to have to work closely with schools and with the medical providers to make sure that we're all on the same page.
Matt, we only have a few minutes left, so maybe time for one or two more questions. I'm going to ask you an extremely naive question. So why did we have a readily available vaccine and treatment? Was this because we were worried about smallpox and bioterrorism, or was this to treat monkeypox in Africa?
Yeah, no, thanks, Eric, because I don't think I clarified that well enough in my presentation. So for the Jynneos vaccine, okay, it was originally in the 2000s, was developed as so Dryvax is the classic, historic smallpox vaccine, okay? Then Jynneos was, then ACAM 2000 came after it. ACAM 2000 is very similar to Dryvax, but it's produced in a cellular process. It's just produced in a more modern process. But ACAM 2000 is a live vaccine, and so has had certain concerns because of it. Jynneos was developed as a smallpox vaccine that is a non-replicating vaccine, so much lower, lower risk of side effects. Back in 2019, based on the fact that monkeypox was out there, the FDA and the CDC reviewed Jynneos and felt like the data really indicated that this was a safe and effective vaccine against monkeypox. So this is not a situation where right now we're just saying, oh, wait, Jynneos can be utilized against monkeypox. Really, two or 3 years ago in 2019, the CDC and the FDA reviewed this data and said that this vaccine not only works against smallpox, it works against multiple orthopoxes, including monkeypox. The intradermal change, that's relatively new, but we've been prepared. They've been prepared for this issue for a while. Tecovirimat has been more in the trial phase. Given the outbreak, given the situation, given the evidence that it's safe in humans, it was felt inappropriate, unethical to wait for trials to continue. We had evidence in animal models that it works. We have evidence in humans that it's safe, and Tecovirimat was licensed by the FDA based on that information.
In the last minute or two, can you just tell us, are there any any final thoughts or any action items that you think that we as providers should take, even as simple as calling this Mpox instead of monkeypox?
Yeah, which I have to get better at myself. That's the CDPH guidance, Mpox. I think that I think it is important to be mindful of disease, but I think it is also important not to overreact and stigmatize and create and worry about risk where there isn't any. Just for example, I think one question I've had is, well, if I have someone who comes in who may have monkeypox, do I keep them from sitting in my waiting room, or do I have to find a place for them to go right away? Well, the risk of transmission in those settings is so low, you really do not need to pull out people who are at potential risk. I think those issues and I think for all of us, recognizing that yes, close contact certainly poses a risk. As a healthcare provider, use appropriate PPE. If you've been exposed to a case, think through what your risk really is, but recognize that let's be proportional in recognizing the risk here. Be mindful and work hard to keep our patients safe, but be mindful of the risk and the limits to that risk.
Dr. Zahn, thank you so much. This was fantastic. We really appreciate all the good information you shared with us. Just to close, wanted to share with you some resources that are available from CDPH, and the links are in the chat. There's also some social media messaging that CDPH has put out. And again, you can find that all at the CDPH website. And then here is some CDC messaging and information for your offices. Again, that's in the chat as well. At the end of this, an evaluation is going to pop up. It takes just a minute or two. It's important for us to let us know where we should move forward with these conversations as we are getting better at treating COVID. We want to kind of continue this with other kind of emerging infectious disease issues such as monkeypox. And so hopefully this will continue moving forward. So let us know what you want to hear in the future. We'll probably have something coming up about variant and bivalent COVID vaccines. I assume that'll be the next thing we talk about in a month or so. But please let us know using that evaluation. And thank you for everything. Thanks for protecting California. Thanks to our co-sponsors, the AAP California, California Academy of Family Physicians, California Department of Public Health, and of course, the California Immunization Coalition. And we look forward to seeing you soon. Thanks so much, everybody.